Hey, it's Adam Sewell, MD. Welcome to Section 5.3 of the Microplastics Toxicity Training, certified by the Microplastics Health Alliance. In this module, we're going to focus on two of the most critical organ systems for effective detoxification, the gut and the liver. These organs aren't just involved in digestion and metabolism. They're the central hubs for mobilizing and clearing the residues of microplastic exposure. Whether you're dealing with BPA, phthalates, nanoplastics, or the inflammatory proteins they provoke, the detoxification process almost always begins with the intestinal barrier and hepatic detox pathways. Part 1. Why gut and liver function matter in microplastic detox. To understand why these systems matter, we need to start with how microplastics interact with tissue. When ingested, microplastics and their chemical residues, like phthalates and BPA, first come into contact with the intestinal lining. These particles compromise tight junction integrity, increase intestinal permeability, and activate local immune responses. From there, absorbed plasticizers are transported via the portal vein directly to the liver, where they're processed by phase 1 and phase 2 detox enzymes. If these systems are sluggish, undernourished, or inflamed, mobilized toxins recirculate instead of being eliminated. This is known as enterohepatic recirculation, and it's one of the biggest barriers to successful detoxification. Part 2, the GI barrier, clinical targets and immunohistochemistry. Let's talk gut lining. In patients with microplastic exposure, we often see evidence of low-grade intestinal inflammation and mucosal barrier compromise. On biopsy, this may appear as reduced expression of tight junction proteins such as zonulin, occludin, and claudin. We also see increased infiltration of CD68+ macrophages and CD3+ T cells in the lamina propria, indicative of immune activation. This is not just academic. When the barrier is compromised, bacterial L, PS, undigested food particles, and chemical toxins re-enter the bloodstream and drive systemic inflammation. This is the gut-liver axis in action. Clinical reference Zolotova et al. 2025 reported that microplastic exposure in mice induces oxidative stress, increases intestinal permeability, promotes immune cell infiltration, upregulates pro-inflammatory factors, and reduces mucus production, hallmarks of colonic inflammation, barrier disruption, and immune activation. Wang et al. 2025 demonstrated that ingestion of microplastics can impair the gut barrier and elevate local pro-inflammatory cytokines, specifically tumor necrosis factor alpha and interleukin-6 in rodent models. Part 3, gut treatment protocol, 3 steps. Step 1, remove irritants and bind residual toxins. Discontinue gluten, processed dairy, synthetic emulsifiers, and inflammatory oils, for example, soybean, corn. Introduce dietary fiber, 10 to 15 grams a day, acacia gum, psyllium husk, partially hydrolyzed gar gum, PHGG, binds bile-based plasticizers and supports microbiome diversity. Step 2, repair mucosal lining, L-glutamine, 5 to 10 grams per day. Primary fuel for enterocytes, zinc carnosine, enhances tight junction expression and mucosal healing. Sodium butyrate or calcium magnesium butyrate, short-chain fatty acid that nourishes colonocytes and reduces inflammation. Aloe vera, decolorized inner leaf only, soothes mucosal surfaces and reduces INOS expression. Step 3, reinoculate and modulate the microbiome. Use probiotics with Lactobacillus rhamnosus GG, Bifidobacterium longum, and Saccharomyces boulardii. Support SCFA production with prebiotic fibers. Berberine or oregano oil may be used cautiously in dysbiosis overgrowth cases, but should be avoided in advanced gut barrier injury. Expected timeline. Patients often report less bloating and improved stool form within 7 to 10 days. Histological repair of the mucosal barrier occurs over 8 to 12 weeks, depending on severity and adherence. Part 4, the liver. Mobilization. Through phase 1 and phase 2 pathways, once plasticizers enter the bloodstream, they're processed in the liver. Phase 1 detoxification, primarily via cytochrome P450 enzymes, adds reactive groups to toxins, making them more water-soluble. Phase 2 detoxification conjugates these toxins using methylation, sulfation, glucuronidation, or glutathione conjugation so they can be excreted via bile or urine. Problems arise when Phase 1 is overactive, leading to reactive intermediates. Phase 2 is underactive, leading to toxic buildup. Bile flow is impaired, leading to recirculation. Clinical clues: elevated GGT, borderline high ALT/AST, constipation or pale stools, bile stagnation, elevated estrogen or SHBG due to reabsorbed estrogens. Genuis et al., 2011, Human and Experimental Toxicology, reviewed conjugation pathways relevant to plasticizer elimination. Yue et al., 2025, reported that chronic microplastic exposure can lead to hepatic mitochondrial damage, including impaired membrane potential, increased oxidative stress, and metabolic dysfunction in liver cells. Part 5, supporting liver detox, nutraceutical and botanical approaches. Phase 1, modulators, balancers. Resveratrol, green tea catechins, rosemary, moderate CYP activity, reducing toxic intermediates, milk thistle, silymarin, antioxidant hepatoprotection. Phase 2, cofactors, support conjugation. N-acetylcysteine, NAC, replenishes glutathione. Glycine, taurine, magnesium B6, S-adenosylmethionine, methylfolate, support methylation and sulfation pathways. Calcium D-glucarate, inhibits beta-glucuronidase, reducing reabsorption of glucuronidated toxins. Bile flow enhancers, phase 3 pathway support. Phosphatidylcholine, PC, emulsifies bile, supports cell membranes. Dandelion root, artichoke extract, beetroot, traditional cholagogues. Tudka, toror sodioxycholic acid, potent bile acid used in liver disease and cholestasis. Part 6, sequence and safety and mobilization. Mobilization should never begin until elimination routes are open. Patients with constipation, SIBO, or impaired liver enzymes should stabilize first before upregulating detox. In some cases, mobilizing stored plasticizer residues too aggressively can lead to Herxheimer-type reactions, headaches, fatigue, irritability, and skin rashes. These symptoms are due to cytokine release and toxic recirculation. Always monitor GGT, bilirubin, and bowel movements during phase 1/2 upregulation. Suggested sequence: weeks 0 to 2, open bowels, initiate gut lining repair, basic liver support. Weeks 2 through 6, upregulate conjugation pathways, continue bile support. Weeks 6 to 12, begin targeted mobilization protocols if labs and symptoms are stable. To summarize, gut and liver support form the foundation of any successful microplastic detoxification program. These organs are not just routes of elimination, they're also major sites of damage from synthetic compounds. When we restore mucosal integrity and hepatic detox function, we not only facilitate toxin clearance, but we also reduce systemic inflammation, improve hormone regulation, and support cognitive recovery. In the next section, we'll explore how to activate phase 3 elimination, specifically through sweat and kidney pathways, and how to design safe, effective protocols for mobilizing toxins through perspiration and renal clearance. I'll see you in section 5.4.